Now we're going to talk about the geometric factors. Geometric factors have to do with lines and keeping lines parallel to or perpendicular to the anatomy that we need to see to minimize distortion, uh, reduction in object image distance so that we minimize magnification, utilizing adequate or possibly when to increase source to image distance so that we minimize magnification, and then use of focal spot in order to increase sharpness of recorded detail. So geometric factors are really pretty synonymous with sharpness of recorded detail. So magnification is considered size distortion, and it is where we have an increase in overall size, and it's equal across the anatomy or the object that we're discussing. So it's considered size distortion. It results in a loss of sharpness of recorded detail, and it's the sharpness of recorded detail I mentioned a few days ago. The umbra is the actual sharpness. The penumbra is the loss of sharpness. So how the penumbra is going to manifest itself is in a couple of different ways. And it is often, I find helpful um, to use light and shadows to understand magnification, penumbra, distortion, sharpness, and geometric factors. So if you can, turn off the lights in the room, get a flashlight, get a couple of different flashlights if at all possible, preferably one that has light emitted from a fairly large linear array of light bulbs, like fluorescent light, and one that's an incandescent light with a very small, where all the light comes from a very small spot. So if you're looking at your shadows, what you'll find is that anything that increases magnification is also going to increase the penumbra and reduce the umbra. So you will have or demonstrate an increase in magnification whenever you've already got an increase in OID if you decrease your SID. What I mean by that is that if you have no OID, then adjusting your SID up or down, if you increase or decrease your SID, you'll see a minimal amount of change in your penumbra or your magnification. So let's start with maybe a 4-inch SID. If you hold your hand above your table with the lights off, or above your book with the lights off, and shine a flashlight under your hand, the shadow of your hand is going to be larger than your hand itself, if only by a little bit. Now at that distance, the penumbra, depending on how far your SID is, how far your flashlight is away from your hand, your penumbra might be insignificant. But if you move your hand towards the flashlight, what you'll see is an increase in magnification, and the closer you get it to the light, the fuzzier the edges appear. So you lose umbra, the lines aren't all that sharp. You introduce penumbra, the anatomy or your shadow gets fuzzier the closer you get to the light. So with a set SID, an increase or a decrease in OID changes your umbra and your penumbra. If you increase your OID, let's say you went from 4 inches to 8 inches, then you can increase your SID, and your shadow will again return to about the same size as what it was at 4 inches. If you double your OID and you double your SID, then your magnification and your sharpness of recorded detail should remain the same between those two ratios. All right, so what increases OID? The things that increase OID would be body habitus, body thickness, body position, uh, and object shape, and really anatomical construction. So body habitus. If you have somebody who's asthenic versus somebody who's hypersthenic, and both of them have a kidney stone, the kidney is going to be elevated away from the image receptor in a hypersthenic patient further than what it's going to be in the asthenic patient. So the kidneys lie about 1/3 of the way through the patient's anatomy. So if your patient measures 21 centimeters from their back to the anterior most portion of their abdomen, if they measure 21 centimeters, their kidney is going to be roughly 7 centimeters deep. So if they've got a kidney stone, it's going to be somewhere close to 7 centimeters deep. If you have somebody who's they measure, say, 36 centimeters, then it's going to be 12 centimeters deep. So the difference is going to be the first patient who's, let's say, sthenic at 21 centimeters, their kidney and the kidney stone is potentially going to be 7 centimeters from the image receptor. So your OID is 7 centimeters. But if you have somebody who's 36 centimeters, measures 36 centimeters thick, their kidney stone may be somewhere around 12 centimeters OID. So body habitus can change it. Body thickness, along with body habitus, body position. You know, if you take either one of those patients, you oblique them up in either direction as opposed to having them lie flat on their back, it's going to change the OID. If you try to take an X-ray of a patient and their kidney and kidney stone with them prone, then you exactly double the OID. Instead of being 1/3 of the way through the body, it's now your kidney is 2/3 of the way through. So body habitus, body thickness, body position can all affect your OID. C-spines. Remember last semester whenever we talked about the anatomy of interest on an oblique of the C-spine, what we're looking at is the intervertebral foramina. And on an AP oblique, the foramina that we see is the side that's elevated further away from the image receptor. On PA, it's closer to the image receptor. This semester we've studied the skull. When we shoot PA, the orbits aren't as magnified as what they are with a patient AP. So body position can affect it greatly. But body shape can as well, or object shape can as well. If you remember back to last semester, we were talking about wrist bones, and we said that on wrist bones, because of their shape, they're more narrow on the anterior surface than what they are on the posterior surface. The anterior surface is what we usually put down, and we shoot PA projection. And what that gives us is the widest portion of the anatomy is elevated off of the image receptor. And since it's elevated away from the image receptor, the OID of the posterior portion of the anatomy increases in size and increases its penumbra. We said that if we shot our wrist bones AP instead of PA, because of the shape of the bone and the divergence of the central ray being more similar to the shape of the wrist bones, we would reduce magnification and reduce penumbra. In other words, it'd be better to shoot AP than PA because of the shape of the bones. Spherical shaped objects are always going to have an increase in OID. Think of a ball. The fattest portion of the ball, if it's provided it's not flat, but if you have an inflated ball, the fattest portion of the ball is always going to be above, elevated away from whatever object you put it on. You put it on a table, fattest portion of the ball is going to be halfway through the height of the ball. So you can't get a 0 OID on an object that's spherical in shape. A round shape object is always going to have magnification and a loss of penumbra. Can't overcome it. So magnification, there's two different ways to calculate magnification. Magnification is equal to the image size over the object size. So it's a ratio of the size of the actual image, size of the actual object. It can also be calculated as magnification factor is equal to SID, that's source to image distance, over source to object distance. Your DeAngelis is a great tool for working through problems, for math problems. There are a lot of magnification factor problems inside of your DeAngelis book. So magnification is controlled with SID and OID. Magnification uses SOD. So magnification factor uses SOD. So SOD is equal to SID minus OID. SOD is source to object distance. So that's the distance between the X-ray tube and the object that you're shooting. That's your SOD. And it is equal to source to image distance minus object to image distance. So what we want is minimum OID. We want acceptable SID. It's impractical to shoot everything at 72 inches. So we need an acceptable SID. So if we have increases in SID, then we can use an increase, if we have an increase in OID, we can increase our SID to accommodate or to compensate for that increase in OID. Again, going back to your magnification factor, if you double one and you double the other, then it's basically a wash. You don't have any kind of magnification factor or increase in magnification. You still have a magnification factor. Your magnification factor will always be at least 1, almost always greater than 1, which means you always have magnification present on an image. Even if the display doesn't look like you've got magnification, there's always some magnification there. Soft tissue prevents your anatomy, even in your extremity work, prevents your anatomy from being in direct contact with the image receptor. What I mean by that is your bones never rest directly on top of the image receptor. There's always soft tissue on top of it that increases your OID. It may be insignificant, but your magnification factor is always going to be above 1 because of that. So magnification, no image is without magnification. Soft tissue provides an increase in OID in tabletop images. If you're using the Bucky, then you're going to increase your OID by sometimes as much as 4 inches. So image size does not always demonstrate magnification, but it is present. Your image size on your monitor might actually be smaller than the actual anatomy, but that's only because of the image manipulation in the computer system, the image display. The magnification was there already. It's just the display that changed. So actual image size is determined by the exam selected and the collimated field that you use. So one of the complaints that radiologists are expressing lately is the size of the image that they actually receive. Since collimation plays a part in how the computer reads how large anatomy is, if you fail to collimate, if you don't collimate to prescribed amounts of collimation, which is usually a half an inch from the edge of the anatomy, then the computer is going to read the entire radiation field. So if you shoot a finger on a 17 by 17 inch image receptor without any kind of collimation, the computer is trying to make sense of this entire irradiated field that's 17 inches in one dimension by 17 inches in the opposite dimension, and you told it that there's a finger there. So what's going to happen is the display on the monitor is going to make the size of that finger minuscule. It's going to read that entire image receptor as being representative of the finger. So the entire collimated field comes up on the computer, but the finger, the actual anatomy, might only be 1/4 of an inch tall. So very, very important to include your collimation and collimate in as closely as possible without over collimating and clipping anatomy that needs to be seen. So make sure that you collimate, because the display is going to be affected by it. So magnification factor is always going to be 1 or something. It's going to be 1 point something, 1.1, 1.5. Gets to be a little extreme, but it's going to be 1 point something. So on your slide, that does not just mean it's going to be 1 something. It's going to be 1.1, 1.2, 1.3, something, 1.01. It's going to be greater than 1 is the point there. So the percentage of magnification is what's going to be after the decimal. So what I mean by that is if we have a magnification factor of 1.1, that means you've got 10% magnification. All right. So the 1 represents the actual size of the anatomy, and what that means is you've got 10% magnification. Like that. For example, an image is made with a 40-inch SID and a 2-inch OID. What is magnification factor? So we've got our SID, we've got our OID, so it'd be sit over sod. Our sod, of course, would be our OID, our SID minus our OID, so it'd be 40 over 38. So what is our magnification factor? So again, 40 divided by 38 would be 1.05263315. So it'd be, the image is 1.05 times as large as the object. So the percentage of magnification is 5%, that being that the image is 5% larger than the object. So what if we increase the SID and the OID? So we change our SID to 80 and maintain the same OID. So we still got a 2-inch OID, so our SOD would be 78. So in that, we reduce our magnification because we increased our SID and we maintain the same OID. Our magnification decreased to 1.25641, which is roughly half of what it was before, right? So we have 1.05, now we have 1.025. So if the SID remains at 40 inches and the OID increases to 4, then we've got 1.11, which is roughly twice what that was. So if we increase our OID by a factor of 2, and we increase our SID by a factor of 2, what would you expect to have happen? We can calculate it by dividing our SID, 80, by our SOD, source to object distance, which is now, since we increased our OID from 2 to 4, is 76. So what it should be, I can't give you the answer there, but it should be that. We increased both of them by the same amount. It's a ratio type formula, and therefore if we increase both of them by the exact same percentage, we doubled both of them. We changed each one by 100%. So really we've done nothing to our OID, or I'm sorry, we've done nothing to our magnification. All right. So what we want to do is to have as low of a OID as possible with a reasonable SID, because magnification decreases sharpness of recorded detail. Again, refer you back to your flashlight and your shadow. Anything that increases your magnification decreases your sharpness or recorded detail. Sharpness or recorded detail is considered size distortion, and it gives the radiologist an inaccurate idea of what the anatomy looks like. So if you have a patient that you shoot a chest x-ray AP versus PA, then the heart's going to look more magnified on the AP as opposed to the PA, because the heart is more anterior in the thoracic cavity than posterior. So there's going to be some magnification of the heart. Can affect the patient's outcomes. So magnification increases as SID decreases, so it would decrease as SID increases. It increases as magnification increases, OID increases, so it would decrease as OID decreases. It increases penumbra, and it's more prevalent with hypersthenic patients, thicker body types, and can change with body position and object shape. I did touch on something the last time we saw this slide, and that was exam type. There are certain exam types that you cannot get minimum OID for, lateral C-spine being an example. In order to visualize C7T1, you're going to have to put the image receptor down past the upper portion of the patient's shoulder, which is going to elevate the spine itself away from the image receptor. So if it's away from the image receptor, we have an increase in OID. The increase in OID, we have magnification. So we shoot those exams naturally at a longer SID. So most of the exams that we shoot at 72 inches, what we're trying to do is we're trying to overcome the magnification and loss of sharpness or recorded detail. We're trying to reduce the penumbra and reintroduce that sharpness, and again try to represent the anatomy in more of its normal size. So exam type also can drive magnification. So distortion, as opposed to magnification, is unequal magnification. So when you're reading test questions, pay attention to what it's asking you. Words mean things. So if the question is asking about equal increase in size is magnification. If it asks about unequal magnification or unequal increases in size, now you're talking about distortion. Magnification has everything to do with SID and OID. Distortion has everything to do with lines and parallel versus perpendicular relationships. So unequal magnification. So if you have your flashlight, what you can do is you can tilt an object in the light field and see what happens to the appearance of the object. What you'll get is, as something tilts up, like on my desk right now is a pair of scissors. If I tilt the pair of scissors up to where the sharp end is closest to my desk and the handle elevates, then what I'm going to get is a distorted view of my handle, and really the scissors all the way across the board, but I'm going to have magnification of the handle where I'm not going to have magnification of the point of my scissors. The tip of my scissors is not going to be magnified, the handle will be. So what we get is unequal magnification. What's elevated magnifies, what is not elevated does not magnify, but it changes the relationship between the length of the anatomy and the image receptor, and if you're using a flashlight, the light field that's shining on the object. So it's going to distort. It's not only going to magnify one end over the other, but it's also going to change the shape within the shadow, and therefore it's going to misrepresent the appearance of the anatomy as well. So where we get distortion is where we have central ray angulation, or part angulation, or image receptor angulation, one of the three. So with central ray angulation, think of your towns. So you just took a test on towns. You can look back in your Merrills and look at the towns, and what you'll see in a towns and a Haas is because of that great angulation on the central ray, the head looks alien. It looks really, really long. And again, get an image receptor. Go in a room in clinicals. Take some x-rays of some things that and angle the central ray, and you can see how this works. Structures that have a natural increase in OID are going to be greatly affected by distortion of central ray angulations. That's why the towns looks the way it does, is because the head is almost spherical in shape. So you got a natural increase in OID. So angulation of central ray generally causes elongation. Off-centering, though, can also cause this. Because of the divergence of the central ray, you want to put the anatomy of interest directly in the middle of the central ray. If it's off to the side, then what you're using is a divergent central ray to make an x-ray. So you're naturally going to get distortion there as well. You can see this if you took one of those small jugs of barium that's maybe the size of a, I don't know, traveling cup, a travel mug, and you place it right in the middle of the table, pull the fluoro tube across and lock it in, and then fluoro over the top of that jug of barium, you'll see the change in the appearance of the jug of barium in the periphery of the radiation field. What you've got going on there is what you call the parallax effect. The parallax effect is change in appearance because of position, basically. So if you off-center from the anatomy of interest, that anatomy is going to be distorted because what you're utilizing is an angulation on your central ray. So central ray issues usually cause elongation. Image receptor issues do as well. So if you have a tilted image receptor, then what you have in a lot of cases is an appearance that looks like you've got an angulation in the central ray. If, though, you have part misalignment, like what we were talking about with the scissors a minute ago, then what you're going to have is, with part misalignment, you're going to have foreshortening. It is magnified on one end, but the overall length of the object is going to be short. I think that in the Bouchon book, there's a picture, I think it's 3 different pictures of a humerus that demonstrate the different types of distortion. So foreshortening, the arrow, as it's tilted up, you got foreshortening, so that the central ray here, the perpendicular portion of the central ray, is really showing you 2 things. It's showing you elongation and foreshortening and magnification. Because of the increase in the OID, we've got an increase in size because it's not in the center of the central ray, but we're using the peripheral portion of the X-ray beam. We've got a not only a magnified but an elongated image. So the anatomy, the arrow, is only this big, but the shadow of the arrow is that large. But whenever we tilt it up, we get foreshortening, so the appearance of the size of the arrow is much shorter. So foreshortening and elongation on both of those. So the factors affecting distortion, you've got object thickness, you got object position, you've got object shape. So object thickness, the increased thickness causes magnification. You got body habitus, you got specific anatomy, and where it's located within the structure. Because of where it's located inside of the structure, you can't get it closer to to the image receptor, so you've got a natural increase, no ID. So we talked about this before. Object thickness increases tissue magnification. It's controlled by body habitus, specific locations, specific shapes. But now if you utilize any kind of an angulation with the already increase in magnification, then things exacerbate. They get worse. So again, back to fluoroing the barium jug, what you will see as you increase the distance from the center of the central ray, from the center of the object field, the radiation field, is that whatever is furthest away, the top of the barium jug, whatever is furthest away, or if you're not using the barium jug, then it will exhibit more distortion because of the increased no ID. In your flashlight, if you took, let's say, a pen, then whatever is closest to the whatever you're casting shadow on, be it your book or your desk, whatever is closest to that doesn't show much magnification, doesn't show much distortion at all. What's furthest away shows the most. Another example would be is if you're walking down the road at night and you approach a street light, your shadow's behind you. As you get directly under the street light, your shadow is right on top of you, or right up under you. You're right on top of the shadow. And as you walk away from the street light and the light becomes more behind you, if you watch your shadow, your feet really don't distort all that much. What does distort is your head. So the further you get away from the street light, the longer your shadow becomes, and the longer everything becomes, but your feet really remain the same. So the size and the shape of the object that you're recording, or the object that you're imaging, is greatly affected by the angulation of the central ray. So here we're talking about the parallax effect, object position in the central ray versus out of the central ray. But in the central ray, another example, much like what I'd mentioned before with the wrist bones, is the lumbar spine. Lumbar spine, because of the lordotic curvature of the lumbar spine, if we're really interested in seeing the intervertebral disc spaces, it would be better to shoot PA, because the lay of the lumbar spine would be more in line with the divergence of the central ray. The disc spaces would be more in line with the divergence of the central ray. So anything away from the central ray is inherently going to create more distortion because of the divergence of the central ray, and it's a lot like angulation. So parallax effect is what we're really looking at there, and it may create superimposition by projection of the divergent central ray. If you have ever done a myelogram with a radiologist or a physician's assistant, where they want to see the pointed end of the needle is right in the middle of the radiation field. The reason for that is because in that area, right in the middle of the radiation field, they know exactly where the needle's going. If you get the tip of the needle outside of that, then there's really no telling where the needle's going. It's really dependent on how deep the needle is already inside of the patient's back, where the patient's spine is in relationship to their back. They just can't tell, so they need to see it right in the middle. Anywhere else gives them a parallax effect, and they can't predict exactly where they're sticking the needle. That's a bad situation if you're a patient too. So types of distortion, we got unequal magnification, that is your elongation and your foreshortening. Elongation misrepresents the size and shape of the anatomy. It appears longer than what it is. It's usually caused by central ray angulation and or image receptor misalignment. It may be evident in the divergent central ray, and that may be worse at short SID and SOD. So if you remember back to last semester, we talked about AC joints. And I recommended that you shoot AC joints at 72 inches. And the reason I recommended that was because of the divergence of the central ray. In a lot of cases would project the AC joints as shoulders, the AC joints off of the image receptor. So if you back up to 72 inches, you have a much more perpendicular central ray. The divergence isn't as bad, and you can usually get both of the AC joints on the image receptor. So foreshortening, things appear shorter, but one end appears to be much larger, so you get unequal magnification. And it's usually caused by anatomical misalignment. And then object shape, spherical objects, L-spine, wrist bones. If the shape of the object is more in line with the divergence of the central ray, your sharpness of recorded detail is going to go up. Spherical objects, you just can't overcome a loss of umbra, introduction of penumbra, and magnification. It's always going to be present in a spherical object. So I'm going to stop there, and we'll do one more on focal spot blur maybe tomorrow.